Thank you for inviting me to talk today. I'm going to speak on postmenopausal hormone replacement therapy, coronary heart disease, and the timing hypothesis. I have no relevant financial conflict of interest to disclose, and my objectives are listed here. We'll review prospective cohort data on hormone replacement therapy and its effect on coronary heart disease. We'll discuss the timing hypothesis relative to menopausal hormone replacement therapy. We'll talk about the ELITE trial and the most recent WHI data from 2017 and their relevance to clinical guidelines. And we'll briefly touch upon those guidelines in regard to coronary heart disease. I think many of us in the room remember observational data and then prospective cohort data that suggested that hormone replacement therapy was beneficial in postmenopausal women, and in fact associated with a 50% reduction in the risk of coronary heart disease. Mechanistically, we believe that this effect was due to favorable effects on the lipids, including HDL and LDL. As a result of our beliefs in the positive effects of hormone replacement therapy, in the 1990s, approximately 30% of women took postmenopausal hormone replacement therapy. Then an earthquake struck in the form of the HERS trial. This was a secondary prevention trial, and it showed that combined hormone replacement therapy resulted in an increased risk of major adverse cardiac events at 1 year and had no benefit with further follow-up. I remember that many of us awaited the primary prevention trial, thinking that there would be benefit in women who had no established coronary heart disease. And so we were hugely disappointed when the Women's Health Initiative was published in 2002. This also showed that combined therapy resulted in significant increases in major adverse cardiac events and stroke. Furthermore, estrogen alone resulted in an increased risk of stroke and no significant benefit and no protection from coronary heart disease events. I've blown up the Kaplan-Meier curves here slightly. This is for coronary heart disease, and the hazard ratio was 1.29. For stroke, it was 1.41. And out of interest, I've also illustrated the hazard ratio for pulmonary embolism here on combined therapy. The media had a heyday with this. On July 10th, 2002, the New York Times had a headline that read, "Hormone Replacement Therapy Study, a Shock to the Medical System," and indeed it was. Time and Newsweek, the week of July 22nd, 2002, both ran the following covers. We had droves of women coming into the clinic asking to stop their hormone therapy and looking to find other solutions for postmenopausal symptoms. They started black cohosh, they started clonidine, and they started SSRIs seeking relief. Well, skip ahead to 2013 when the post-intervention and cumulative data of the Women's Health Initiative trial was published. And during cumulative follow-up, the investigators found the hazard ratios for coronary heart disease were 1.09 for combined therapy, and for estrogen alone, 0.94. For combined hormone replacement therapy, there was a non-significant difference by time since menopause with a p-value of 0.81. But significantly, the investigators noted that for estrogen alone, there was a trend for lower risk of coronary heart disease events in younger women. And the p-value for the trend was 0.08. This was not only intriguing, it was worthy of further consideration. The investigators from the Women's Health Initiative speculated that in the observational trials, the women were younger and closer to menopause when they started hormones. In fact, they were approximately 50 years old and within 2 years of menopause when they initiated their therapy. However, in the randomized trials, and somewhat artificially, the women had a mean age of 63 years and were usually 10 years or more since menopause. And so the investigators postulated that the effects of hormone replacement therapy on atherosclerosis and coronary heart disease depend on the timing of the initiation of the hormones relative to menopause, the age of the patient, or both. In order to investigate the timing hypothesis, Hodis and his group designed the ELITE trial. ELITE is the early versus late intervention trial with estradiol. The group took 643 women without coronary heart disease and stratified them according to time since menopause. One group was 6 years or less since menopause, and the second group was 10 years or more since menopause. The women were subsequently randomized to either estradiol alone estradiol with a progesterone gel if the uterus was present, placebo alone, or placebo with placebo gel if the uterus was present. The primary outcome was the rate of change of carotid intima media thickness as assessed by ultrasound every 6 months. The women were followed for 5 years. A secondary outcome was the burden of coronary atherosclerosis as assessed by coronary CTA. The CTA was done when the protocol was complete in a subset of women. What the investigators found was that when compared to placebo, estrogen resulted in a significantly lower rate of progression of carotid intima media thickness among the early postmenopausal women, but not amongst the late postmenopausal women. And this was independent of whether the women were additionally on progesterone. The cardiac CTA at the study's completion indicated no significant difference between the estradiol group and the placebo group in either the late or the early postmenopausal stratum. Unfortunately, the CTA was done in only a subset of women, and there were no baseline measures for comparison. The Kaplan-Meier is shown here for the carotid intima media thickness. So ELITE suggests that favorable responses of estrogen receptors in the endothelium may be lost with a lack of exposure to estrogen. This is certainly consistent with the animal studies that have been done. And in gorilla studies, it has well established that the estrogen receptor is responsible for the positive vascular and anti-inflammatory effects of estrogen. And animal studies have further shown that there's a loss of this response with either older age or prolonged estrogen deprivation. Unfortunately, the extension of the results from ELITE to clinical coronary heart disease and major adverse events is tenuous at best. We know that carotid intima media thickness is a surrogate marker of coronary heart disease events. ELITE was not designed or powered to detect clinical events, and also remembering things like niacin. Interventions that improve carotid intima media thickness do not always result in lower event rates. In 2017, the Women's Health Initiative published follow-up data, and what they published said that amongst the postmenopausal women in the WHI study, combined hormone replacement therapy and estrogen alone were not associated with the risk of all-cause cardiovascular or even total cancer mortality during a cumulative follow-up of 18 years. The hazard ratio was approximately 1, and on the background of ELITE, this is quite intriguing. It is made even more intriguing that there was a statistically significant trend for lower mortality in the younger women from cardiovascular causes. And in fact, this p-value was 0.002. This was likely influenced by a burden of adverse events in the estrogen group in the oldest age groups, which were women 70 to 79 years. I'm going to conclude by stating that long-standing evidence suggests either no benefit or increased risk for major adverse cardiac events when hormone replacement therapy is used in postmenopausal women. Researchers continue to investigate the idea of a timing hypothesis. The ELITE trial supports this hypothesis that postmenopausal women may have beneficial effects on atherosclerosis when hormones are initiated soon after menopause. And while extrapolation of these results to clinical event rates is certainly premature, data published in 2017 from the Women's Health Initiative also supports this theory. Nonetheless, the definitive conclusion that postmenopausal hormone replacement therapy reduces major adverse cardiac events, if timed correctly, has not yet been obtained. And therefore, there are no recommendations that promote the use of menopausal hormone replacement therapy for cardiovascular prevention at this time, even in the most recent guidelines for primary prevention from the ACC published in 2019. Therefore, clinicians are still advised to review each woman's risk factor profile to make a tailored assessment of her risk and have a shared decision-making discussion when menopausal hormone replacement therapy is considered, even when the woman is in a younger age group. Thank you.